That varies a lot. It depends on what you eat, on whether or not your urine is concentrated and dilute. I always tell the students it's not the urine, the appearance of the urine. It helps you if it's like if you have like definitely like pink color, or if you have like ATN. When you see a Foley catheter, just move the Foley catheter and you'll see all that sediment. That's very consistent with ATN. You can make the diagnosis of ATN just by walking in the room and looking at the urine. But yeah, so but typically kidney disease patients, or we're talking about nephrotic syndrome patients, they develop eyelid edema, and that can happen anywhere. It can happen even in severe heart failure, but in kidney disease patients, it's characteristic. So the other thing that can happen in kidney disease and proteinuria, anasarca from kidney disease, is that the patients may have hypertension, and the reason being depends on whether or not the patient is nephrotic or nephritic. We're going to talk about it in a minute. But hypertension can be a sign in the setting of kidney disease. The nails of these patients, they can have you heard about Lindsay nails? They look like completely white. 50% of the nail bed is white and the other 50% is pink. And that's usually seen in severe hypoalbuminemic states, like severe liver disease or severe nephrotic syndrome. So you can see changes in the nails. Patients can have very dry skin. They can have, I would say, probably those are the signs and symptoms. It's very non-specific. Okay, so why don't we read the third paragraph, please?
On physical exam, he appears grossly edematous and puffy. His BP is 145/98, pulse 92, respiration 16, and temperature 98.6. The patient's skin shows no signs of jaundice or telangiectasias, no signs of pulmonary erythema. Face shows swollen eyelids but sclera are not icteric. Examination of the neck shows no signs of jugular vein distension and no thyromegaly. His lungs are clear to auscultation and percussion, with the exception of decreased breath sounds and dullness to percussion in the bases. Cardiac exam revealed a non-displaced PMI, normal S1 and S2 without murmurs, rubs S3 or S4. Abdominal exam showed the liver to be approximately 9 centimeters in size. No splenomegaly was appreciated. There were findings of shifting dullness to percussion of the abdomen. In the periphery, the patient had a 4+ pitting edema at the level of the sacrum and throughout both legs. The patient had no signs of gynecomastia, testicular atrophy, or carotid swelling. The patient's neurological exam is normal.
Okay, so given this exam, do you think the patient has CHF, or this is as a cause of his generalized edema? Doesn't look like, right? Mm-hmm. Okay. Are there any signs of cirrhosis present on his examination?
No.
Yeah.
Just the shifting.
The shifting dullness, but you can see that you can have nephrogenic ascites, and that's the reason why I put it in, because when you see ascites, it's not always liver in origin. You can have cardiogenic ascites, and we see that in patients with severe right heart failure. And in fact, it's one of the differentials of end-stage liver disease or non-alcoholic liver disease. End-stage liver disease, you have to rule out severe right heart failure, because that causes hepatic congestion, and when it's prolonged, it can cause it triggers a lot of fibrosis and further damage to the liver. So remember, ascites is not always from the liver. It can be cardiogenic, it can be from the liver, or it can be nephrogenic. So that's the reason why I put it in there. Okay, so what aspect of his examination suggests that this patient has nephrotic syndrome?
Swollen eyelids.
The swollen eyelids. And I forgot to mention that patients with nephrotic syndrome, they get a lot of pleural effusions. And I get consulted a lot on patients, and they think it's all cardiogenic because they probably see a little bit of diastolic dysfunction on the echocardiogram, but they have a preserved ejection fraction. And when you look at in detail, these patients have severe, massive proteinuria, and they present with pleural effusions. So they can present with ascites, they can present with pleural effusions, they can present with this anasarca and the eyelid edema, like you mentioned. So which labs will confirm the diagnosis of this is from the kidney?
Urinalysis.
There you go. And then what else? And you're going to have this board question 100% guaranteed. You have a patient with a UA that reads no protein, but when they do the 24-hour urine collection, or when they do a spot urine for protein creatinine, the patient has a lot of proteinuria. Why is this happening? You're going to have this question on your boards. It's called the mismatch, proteinuria mismatch, between the UA and between the quantification. So you see that in multiple myeloma. The reason being is that the dipstick doesn't run the sulfacylic acid assay, and the sulfacylic acid assay picks up non-albumin proteins. And remember, in multiple myeloma, it's paraprotein.
Connected by disulfide bonds, so they would pick those up.
Exactly. There you go. So that's the reason why you don't see it on the regular UA. And this is a board question, I guarantee you. So pay attention when they give you the clinical question, and you're gonna see no protein in the UA, but a lot of protein in the quantification. So this patient has a paraproteinemia until proven otherwise. Okay, so yeah, but it's a simple test. Just do a dipstick, and it's pretty positive. If it's a nephrotic syndrome, from intrinsic renal disease, nephrotic syndrome, albumin will.
You said the UA picks up the UA picks up
albumin.
The albumin.
Yeah.
Okay, but not the
paraproteins.
Paraproteins. Okay.
Right. Yeah. So remember that for your boards, because this question always every year they have it on the boards. Okay. So all right. So why don't we read the next paragraph, please?
Okay. A urinalysis revealed 4+ proteinuria with a microscopic exam that revealed several waxy casts, oval fat bodies, no cellular casts, 1 RBC and 1 WBC per high-powered field. Electrolytes included a BUN of 20, a creatinine of 1.3. Other electrolytes, glucose, calcium, and phosphorus were normal. A 24-hour urine collection showed 12 grams of protein and a creatinine clearance of 72 milliliters per minute. LFTs were normal, as was the prothrombin time. The patient's albumin was 1.9 and serum cholesterol was 670. Chest x-rays revealed bilateral pleural effusions without signs of pulmonary venous engorgement or abnormalities in the cardiac silhouette.
Okay. So what do you think is his diagnosis? Nephrotic syndrome. Very good. So what's nephrotic syndrome? That sounds like a very sophisticated word, but what is that?
Hypertension.
Lots of proteinuria.
Yeah, so it's a syndrome, right? So when you have a fever can be caused by infinity of causes, right? Same thing with nephrotic syndrome. The differential is pretty broad. So somebody came up with this distinction between nephrotic and nephritic. Don't ask me why. I think they try to divide it up to be able to alert clinicians that nephritic syndromes are more associated with rapidly progressive glomerulonephritis versus nephrotic syndrome. Nephrotic syndromes are more like slow, and they don't present with a lot of hypertension, whereas nephritic syndrome, they present with more hypertension and more rapid acute kidney injury. Somebody in England made this distinction of like greater than 3 grams, we're going to call this nephrotic, less than 3 grams, we're going to call it nephritic. I think that's a useless classification, but we still use it to this day. We use it in med schools to teach the students to make this distinction. Nephrotic syndrome is it's a very broad classification. Can you guys give me some examples of nephrotic syndrome, or what conditions can cause nephrotic syndrome? And we can go over the differential in a minute.
Minimal change.
Which one?
Minimal change.
Minimal change disease, very good. It's seen in kids, right? In adults, when you see it in adults, what disease? Hodgkin's lymphoma. I have a patient, my first day at Kaiser, when I started working, they gave me a patient who somebody else did a biopsy, a 19-year-old boy with severe nephrotic syndrome from minimal change. And I looked at his chart, and he had like these masses in the spleen that they attempted to biopsy, and they basically, the biopsy was non-diagnostic. I referred the patient to hematology. They blew me off. So like, you know, this is already looked into. We don't want to pursue this, whatever. 2 years after, the guy came to the office. I'm treating him with prednisone, and the guy had relapsing disease. It was a very challenging case. The guy came with a huge lymph node. I sent him immediately for a core biopsy, and the guy had lymphoma. And so I went to the hematologist. He said, like, there's a reason why I sent the patient. It's not just to turn down the consult. And the family was very upset and said, like, well, I refer the patient. It's the only thing I can say. Obviously, you never want to fight with colleagues, so you want to have a very cordial relationship with everyone. But minimal change disease is a disease of kids, If you see it in an adult, you look for disease associations. And the boards, they love that association. Hodgkin's lymphoma with minimal change in disease. Okay, what other diseases do you guys know that are associated with nephrotic syndrome? What's the most common cause of kidney failure in the world? You said it.
Diabetes.
Diabetes, yeah. So nephrotic syndrome from diabetic renal disease. These patients can pee massive amounts of protein. I have a guy who right now he's peeing 45 grams of protein. And the guy's like albumin is like 0.8. He's going like this towards dialysis. There's nothing you can do. There's no therapy for this. You just need to tell the patient very honestly, even if your diabetes is perfect, even if your blood pressure is perfect, you will become dialysis dependent. You start looking for a kidney donor, otherwise you're going to be 10 years in the wait list. So you got to tell them that from day one, because there's really nothing you can do for these patients. So diabetes, diabetic nephrotic syndrome. And what's the pathognomonic lesion in the biopsy? Chemostil Wilson. They're going to ask you that thing. So those nodules that they form. Okay, so amyloidosis, very good. Which disease are associated with amyloidosis? Which diseases?
Other diseases?
Yeah.
Like Alzheimer's?
Yeah, but that's different. Yeah, but it's an accumulation of amyloid protein.
Multiple myeloma.
Multiple myeloma. There you go. That's one of the renal multiple myeloma related renal diseases. There are like 7. Multiple myeloma is a nasty disease in the kidney. It can damage your kidney from interstitial nephritis, from amyloidosis, from light chain deposition, heavy chain deposition disease, hypercalcemia. It's a nasty disease. I mean, it's like one of those things that you want to pick up and treat very quickly. Okay, so amyloidosis, but what other disease states are associated with amyloidosis? You mentioned one. What other disease? For internal medicine boards, they may ask you this. It could be, but remember, every time you hear amyloidosis, think about like inflammation, severe inflammation, rheumatoid arthritis. So the rheumatoid arthritis patients can. I have a patient. I started her on peritoneal dialysis. She developed biopsy-proven renal amyloidosis from long-standing rheumatoid arthritis, and the prognosis is just not very good. This tends to be a progressive amyloidosis. When it's primary amyloidosis, it tends to involve many organs, including the heart. The heart is a favorite target from amyloidosis. It can involve the liver, it can involve the kidneys, and they generally don't do very well. They need transplants. Okay, so what other diseases can cause amyloidosis? So I had a patient one time with chronic osteo that he refused to get an amputation. He developed renal amyloidosis. So think about chronic inflammation, rheumatoid arthritis, chronic osteomyelitis, like multiple myeloma, primary amyloidosis, which is a different entity. Okay. FMF, there you go. You said it. That's actually one of the complications of familial Mediterranean fever in the kidneys, amyloidosis. And it's so commonly seen that we don't even need to biopsy the kidney, because we assume that this is amyloidosis. In fact, when you as a nephrologist, you suspect that the patient has amyloidosis, you shouldn't biopsy the kidney. You should biopsy some other organ, like you do a fat pad biopsy or like a mucosa biopsy, because it's going to give you the same answer, and you're putting your patient at very high risk, because amyloidosis in the kidney is associated with an increased incidence of bleeding. So it's a relative contraindication. When you suspect you're dealing with amyloidosis in the kidney, you don't biopsy. You just try to prove it from other ways. The other thing that's important to know about amyloidosis is that these patients, they have enlarged kidneys. So few things give you enlarged kidneys. One is diabetes, the early phase of diabetic nephropathy, the kidneys become bigger. Another thing is amyloidosis, and another thing is infiltrated diseases of the kidney. Either you have lymphoma of the kidney, or you have like sarcoidosis of the kidney. It can give you a big kidney. So, and you guys know on average roughly what's the size of a human kidney? Is it different for male, females? Is it different if you're taller or you're smaller? Yeah, so it's different if you're taller or smaller. It's different if you're a male or a female, but generally speaking, for a female, average size female is about 10 centimeters. For an average size male, it's about 12 centimeters. But it can be as big as 14 depending on if you're a tall individual. Your kidneys may be bigger. Okay, so, alright, what other diseases are associated with a lot of protein in the urine? You guys mentioned diabetes, you mentioned minimal change disease.
What's segmental?
FSGS, very good.
Yeah, okay.
FSGS is another one. FSGS can be primary or secondary.
Segmental.
For the purpose of your boards, I don't think they're going to ask you anything about primary FSGS. It's a very specific disease of the kidney and it's a nephrology level of knowledge. But they're going to want to find out about disease associations with FSGS. And the more common ones are, you guys know? HIV, what else? Hepatitis.
C.
No, not hepatitis. No, actually, hepatitis is B is for membranous and C is for membranoproliferative. Yeah, but what other diseases are associated with FSGS? Remember the guy, the heroin users?
Oh, heroin users.
So reflux nephropathy from ureal valves in kids is associated with secondary FSGS. And now that we have an epidemic of obesity, FSGS is very common. Secondary FSGS is very commonly associated with obesity, and the treatment is weight reduction, and the patients do improve. There's no specific therapies for this. So they're going to ask you about HIV nephropathy, which is a FSGS. Sometimes they can have a very rapid disease called collapsing FSGS. It's just the appearance on the light microscopy of the glomeruli. It looks like it's totally collapsed. And heroin users. Reflux nephropathy, African Americans, but that's for primary FSGS. And it's interesting because they identify a gene that confers protection against an infectious disease that we see in Africa. It's called trypanosomiasis. It's sickness disease, or how do you call it? Sleep.
African sleep sickness.
Yeah. So that gene confers protection from that vector that carries that disease. But the Native African Americans, from here, they develop proteinuria, and it's actually a risk factor for developing FSGS. The African Americans. Okay, so in FSGS, primary FSGS is a whole topic in nephrology, but FSGS, I see it as a syndrome. It's more like reflective of something happening in inflammation and things like that. Okay, so we cover diabetic nephropathy, minimal change disease, amyloidosis. We cover FSGS. So there's a big group called membranous nephropathy. Membranous nephropathy can also be primary or secondary. Primary, it's a biopsy, it's a diagnosed with a biopsy, but for your boards, they want to ask you about secondary membranous nephropathy, and the disease associations that you're going to look into are: number 1, NSAIDs use. Number 2, they're gonna want to know hepatitis B and membranous, because that's actually the more common association. There are other medications that can give you membranous, including ACE inhibitors, like believe it or not, captopril, which we don't use it very frequently in the U.S. We use it probably for after low reduction in the hospital setting, but we don't do it because it's a medication that requires like 3 or 4 times a day, and it's not practical. But captopril has been associated with membranous, secondary membranous. Same thing as Plavix and ticlopidine. Those 2 antiplatelet agents have been associated with the development of secondary membranous. Infections like syphilis, like secondary and tertiary syphilis, is associated with membranous nephropathy in the kidneys. There are other infectious diseases that are associated with membranous. We cover hepatitis B, syphilis, and we also see it in malaria. Excuse me, and we also see it on the what's the name of that disease that rats can pass on humans? Leptospirosis. You can see it membranous as well. Okay, so again, the treatment for secondary FSGS as well as secondary membranous is to treat the underlying cause. The treatment for primary membranous and primary FSGS is a whole separate topic. We treat it with immunosuppressive agents. For FSGS, we treat with prednisone. For membranous, we treat with calcineurin inhibitors and steroids. And you can even use cytotoxic agents to treat that, but we're not going to talk about that.
Does it respond to prednisone?
They respond.
Does minimal change respond to prednisone?
Oh, beautiful. Actually, minimal changes is, if you were to have a kidney disease, the more benign kidney disease that you can develop is minimal change disease. Assuming you don't have Hodgkin's lymphoma, obviously. Assuming that you have a primary minimal change disease. But, okay, so what other diseases can be associated? So there are other diseases that can cause, like lupus can cause membranous. Lupus is another cause of autoimmune. Lupus can cause 6 types of kidney injury. We're not going to cover that, but it can cause an RPGN picture or it can cause a membranous picture. So, like type 5 is called membranous nephropathy. Okay, so and then the other side,
How about
HSP? Yeah, HSP is another one. HSP is in the spectrum of IgA nephropathy, and IgA nephropathy can be a very indolent, very benign type of thing. It's the most common GN in the world. It's very commonly seen in Southeast Asians, and it's also commonly seen in Hispanics. These patients, they present with microscopic hematuria. We don't biopsy them, and we know that the incidence is much higher in Asian countries because over there they biopsy patients more frequently than we do, because we know that it's not going to change management. If I have a patient with microscopic hematuria and proteinuria less than 1 gram and stable kidney function, why bother biopsying the patient? I can assume that the patient has IgA nephropathy, or there's another entity called thin basement membrane disease. But those patients have a very good prognosis. We don't biopsy unless things are changing, unless the patients have abnormal renal function or they start peeing a lot of protein. But IgA nephropathy can be a very benign condition, but it can also be a very severe condition. It can go from the spectrum of indolent towards the RPGN spectrum, rapidly progressive glomerulonephritis with crescents. And the only way to diagnose this is with doing a biopsy. Right now I have a 19-year-old Filipino with severe IgA nephropathy, and I just finished treating her with Cytoxan, which is, I actually was very hesitant to give her Cytoxan because that can cause infertility. And you know, the girl is only 19, and that make you bald, and it's like giving chemotherapy to someone. I'm glad that we made that decision because she was going into full-blown renal failure. I saw her yesterday, beautiful. Her proteinuria is down to 600 milligrams, and like the renal function came down, the creatinine came down to 1.0. So I'm so happy that she turned around. But just to give you an example, the IgA nephropathy can be very aggressive, but for the most part, it's a benign little hematuria that you see in patients. Okay, so and then the other group of GNs that are very aggressive, or they can be associated with nephritic syndrome. So you mentioned ANCA diseases like Wegener's. We don't call it Wegener's anymore. I think him and Ryder were Nazis, so we removed the privilege of having these names. Oh. So I think right now we call it granulomatous.
Chronic granulomatous disease.
No, it's called granuloma and polyangiitis. Polyangiitis for Wegener's, and for Good Pastures, I think they call it. No, Good Pastures hasn't changed, but the one that they also Church-Strauss. Church-Strauss, they took away that name. Now we call it eosinophilic granulomatous eosinophilic vasculitis or something like that. Yeah. So you know, remember when you go into the topic about vasculitis, so we got small vessel vasculitis, intermediate vessel vasculitis, and large vessel vasculitis. I don't have to, as a nephrologist, I don't deal with large vessel vasculitis. You probably see it in peds, you know, Takayasus, you know, those vasculitis. As a nephrologist, I deal with small vessel vasculitis, but I can also deal a little bit with intermediate or medium vessel vasculitis. The most common one is polyarteritis nodosum. And what disease is associated with that condition? That's also on your boards. It's an infectious disease. And the way you diagnose this is by doing a renal angiogram. And the renal angiogram, you see aneurysms.
Small microaneurysms.
Small microaneurysms. You don't want to biopsy that kidney because you can kill the patient by biopsying that kidney.
Do they look like? Are they multiple aneurysms? Do they
like
look
little,
beads?
very small aneurysms in the renal arteries. It's in the medial vessels. So hepatitis B. So Hep B, that's a board question. You're gonna get it for sure. So Hep B is associated with polyarteritis nodosum. So, but then we deal with small vessel vasculitis, and the small vessel vasculitis can present. You have to have very good clinical suspicion, and you can't miss these diseases. And I'm gonna give you some examples. So, for instance, they give you a question. A patient presents with mononeurotic multiplex. Have you heard about that? Let's say the guy completely normal, out of the blue, like he has like this peripheral neuropathy and can't move an arm. So when you hear that word mononeurotic multiplex, or you have a patient with a mono like involvement of neuropathy involving one limb, you think about small vessel vasculitis. So that can be the presentation of GPA, or formerly known as Wegener's. Another typical presentation is the patient with chronic sinus disease or adults getting otitis media. Otitis media shouldn't happen in an adult unless you're a smoker, or unless you have structural abnormalities of the ears. But if you have a patient not getting better, actually I'm starting a dialysis patient this week that I saw him 2 years ago for acute kidney injury consult in the hospital, and he came after being treated for 2 months by the ENT doctors with multiple rounds of antibiotics, and everybody thought that he had interstitial nephritis because, classic story. I biopsied his kidney when he was in the hospital, and the guy had, I was waiting for the markers, the serology markers, and the guy had ANCA-related small vessel vasculitis. The poor guy, he was on dialysis. I gave him plasma exchange. The guy made it out of dialysis. I was able to maintain him for 2 years, and now his kidneys gave up. It's a pretty bad disease to have, when you don't pick it up early. Okay, so the classic board questions: sinusitis, otitis, pulmonary renal syndromes. So when you get a case on your boards and they patients present with lung and kidney involvement, you think about 3 entities. You think about, could be lupus. Lupus can destroy the lungs. I mean, lupus is a nasty disease. Lupus can go from a very mild disease to a horrible disease. So it can be lupus with pulmonary renal syndrome presentation, and these patients can even present with a complication called diffuse alveolar hemorrhage, that they're coughing up like mounds of blood, and those patients, they need plasma exchange ASAP, otherwise they can die. So you see that lupus, pulmonary renal syndromes. You also see ANCA-related vasculitis. So either there are 3 types. So the ANCA-related vasculitis, we have Wegener's, GPA. We have Church-Strauss, we don't call it Church-Strauss, we call it eosinophilic. And these patients actually, they present with more pulmonary than renal symptoms. These patients, they can present with asthma. They can present with a peripheral eosinophilia. They can present with wheezing. And they can have an active urine sediment. Remember, we talk about looking at the urine? That's where the money is in nephrology. You look at the urine. If you see pyuria, microscopic hematuria, you better get on top of that case, because you may be missing something important. So, and then there is a 3rd category, which is called myeloperoxidase, the MPA, microscopic polyangiitis. So microscopic, those are the 3 ANCA-related vasculitis: GPA, Church-Strauss, and microscopic polyangiitis. So microscopic polyangiitis can present lungs and kidneys, but it's mostly kidneys. So in the other disease that can present in the lungs and the kidneys is called good pastures, and I'm sure you've heard about good pasture syndrome. So good pasture syndrome is when the patients have lung and kidney involvement. It can happen in very young males, and it has a bimodal presentation. It can happen, that's a beautiful picture, I've never seen it. Is that new? Beautiful. So it can happen in the very young males, or it can happen in middle-aged women, like in their 60s, or like middle-aged women in their 60s, or very young males. If you have a young male with hemoptysis and kidney disease, guarantees good pastures. And why is it so important to identify this? Because the treatment is with plasma exchange. If you miss the boat, this patient is going to become dialysis dependent, or you can even die, because it's a very serious, they have like massive autoantibodies against the glomerular basement membrane, and these patients, they go down very quickly, and they turn around very quickly when you start giving them plasma exchange, because you're removing all those nasty antibodies. So those are the 3 diseases associated with pulmonary renal: lupus, ANCA, and good pastures. Good pastures disease or good pasture syndrome can present limited to the kidneys. We call that anti-GBM nephropathy, and it's just the same spectrum of disease, is just involving the kidneys. And again, the diagnosis is by suspecting it, by sending an anti-GBM, anti-glomerular basement antibody, and by doing a biopsy. You don't wait for the biopsy results. If you suspect it, if the antibodies is strongly positive, you need to.
And you would see linear immunofluorescence,
yes,
not spots.
Exactly. That's when you see and the diagnosis is, and renal pathology is based on the immunofluorescence. Remember, renal pathology has 3 components: the light microscopy, they do an H&E staining or whatever staining they need to do. they do immunofluorescence, where we picked up these autoimmune diseases like ANCAS, anti-GBM, and lupus. And we do electron microscopy, which is the last component. It usually takes about 2 to 3 weeks to come back. And that's good to look at the structural abnormalities, like for GNs, like membranous, or for like FSGS. So it's very good by picking up those disorders. So, okay, so diseases associated with rapidly progressive glomerulonephritis. So we have, number one, we have lupus. Always remember lupus. The prognosis of lupus completely changed in the last 20 years after they came up with these protocols for induction. Remember, lupus we treat with Cytoxan, or we treat with Celcept, with mycophenolate. And after they came up with this, the prognosis changed dramatically, because ladies with lupus and kidney failure, the prognosis was pretty ominous. Nowadays, with these treatments, we can put the disease in remission, and these women, they can enjoy good quality of life and a normal life expectancy. But it's important to recognize that, because lupus is always the great mimicker, and they're going to ask you a lot about lupus in your board. So just make sure you remember the mnemonic, the MD soap, whatever, I forgot already. How do you remember the MD, malar rash, discoid, S stands for serositis, O stands for, I don't know, you should Google it, MD soap. But remember to memorize that, because you're going to be heavily tested on lupus. And lupus is a disease that can affect your brain, your kidneys, your skin, your hair, everywhere. Everywhere of your body can be affected by lupus. Psychiatric disease. I had a patient one time that he kept coming to the emergency room with like he was itchy everywhere, and they thought that guy was crazy. The wife said like, oh yeah, his personality is changing, and the poor guy ended up getting admitted, and I'm so glad that we ended up finding that he had lupus, because the guy had 1 year of nobody knowing what was going on with him. And that's a classic presentation. Itchy skin, and he had like this on and off rash, and like it was coming and going. And the reason why they kept him is because the guy refused to go. He kept coming to the hospital, and he refused to go, like, I'm getting admitted. And so they ended up admitting him, and we noticed that he had an active urine setting, and we biopsied his kidney, and we did a biopsy of his lymph nodes, and he ended up having, the doctor weren't examining him correctly, because he had massive lymph nodes everywhere. He had like supraclavicular and like axillary. So whenever they write off a patient, think about it. You just think, is this really writing them off, or think about medical disease? You're going to be doing that a lot. Thinking about medical disease. Okay, so, alright, so RPGN syndromes, lupus, ANCA vasculitis, anti-GBM, IgA nephropathy can present as an RPGN, like I explained, can present like a very mild versus a very aggressive form. And, I think those are primarily the ones that you may get tested on your boards.
Penicillin doesn't cause kidney problem?
It can cause an interstitial nephritis.
Okay.
Yeah, allergic form. Okay, why don't we go to the next paragraph? I think this is laboratory tests were sent.
Oh, do you want me to read it?
Yeah, laboratory tests.
Laboratory tests were sent for anti-nuclear antibodies, serum complement, and fasting blood sugar, which all were normal. A VDRL and hepatitis B and C serologies were also negative.
Okay. Would you recommend a kidney biopsy for this individual? And if yes, why? And if not, why? What do you guys think?
Well, okay, anti-nuclear antibodies negative.
Mm-hmm.
So those are like the ANCAs.
You can still have lupus, negative ANA, negative lupus, but it's very rare. It's only like 1 or 2% of the cases. But it's still possible. I've never seen it. I've only read it in the textbooks, but I've never seen, lupus negative ANA. Okay, so but would you do a biopsy, or how do you select? How do you come up with this thing about like a kidney biopsy? Is this a light procedure? Is this an invasive procedure? Can people die with this, or this is something that everybody should get a biopsy? What do you guys think?
Well, there's probably some risk, but the fact that the symptoms show, like, up to this point, we're thinking he probably has some kidney disease and we're thinking nephrotic syndrome.
Mm-hmm.
And the lab tests, however, come up negative for, some of the, like, for example, Hep B and C, we would think membranous and proliferative, but those come up negative. But still, there might be a chance. For example, membranous might be primary membranous, so we might still want to do a biopsy. Yeah.
So you would favor a biopsy?
I would think so because we think it's nephrotic.
What about
yeah,
you? You favor a biopsy?
I agree with him. I would favor a biopsy.
How about you?
I concur.
I would say the same thing.
Yeah. He needs a biopsy. I mean, not doing a biopsy, I mean, I don't see a reason why not doing a biopsy. So let's talk first about which patients we don't biopsy, because that's important to know, because a renal biopsy is an invasive procedure. It should be, the candidate should be selected individually, not everybody should get a biopsy. And I'm going to give you a few examples. If you have a patient on Plavix, Dr. Pence will put a stent, and if he stops taking the Plavix, that patient will die from instant thrombosis. You don't want to biopsy that patient, because guarantee he's going to bleed to death. The kidney is heavily vascularized, and 5% of the patients can bleed. And one of the attendings, when I was in academics at Oliveview, one of the other attendings, we go to the meetings, one of the other attendings at Harvard, UCLA, she stopped biopsying patients because 2 of her patients died after a kidney biopsy. So it's never happened to me. I stopped doing biopsies. Now I send them to interventional radiology because it's not worth the risk and the time for the money that they pay you for a biopsy. And if you don't have the volume, you start losing your skills, and it's something you don't want to get called with a complication. Let's put it that way. But for the money that they pay you for that, it's funny because interventional radiologists get 3 times more than a nephrologist get paid by doing a biopsy, and it's the same procedure with the same complication rate. And nephrologists do a better job because they go for the cortex. Sometimes radiologists, they end up hitting the medulla, and you're confronted with a complication, and you're telling the patients that they need to do this all over again. Patients, they're furious when you tell them that. Okay, so which patients you don't biopsy? So patients with coagulation disorders, obviously patients with liver disease and like elevated INR. If the patients are on Coumadin, you need to convert them to Lovenox. If the patient is hypertensive, you want to stay away from that patient. If you biopsy somebody with uncontrolled hypertension, chances are you're going to be in court because the risk of bleeding is pretty high. So you want to have controlled hypertension patients, like control defined like systolic blood pressure in the 130s, preferably for 1 week or 2 weeks before you biopsy them. Patients that are very uremic, you can still biopsy them. Let's say you got a case where you have no idea what the hell is going on and you suspect that this patient probably has a bad GN. You want a biopsy to understand the disease and to comment on the prognosis, because the biopsy is not only diagnostic but it's also prognostic. So if I see a lot of tubular atrophy and interstitial fibrosis, that's it. Why are you going to blast somebody with these chemotherapeutic agents knowing that you're doing a disservice to that patient? So that's another utility of doing a biopsy, but not everybody's a candidate for a biopsy. Let's say that you have a patient that is non-compliant. This patient probably benefits from a biopsy, but the next question I need to ask myself as the doctor is, what am I going to do with that information? Am I going to be able to treat this person who's not showing up for the appointments? Is this person likely to be taking the immunosuppressive medications? Or like if a patient is very sick with multiple comorbidities, let's say one of my colleagues, he had a lady with liver transplant, and she was already on prednisone, Cellcept, and Prograf as part of the immunosuppression. My friend biopsied the patient to find out why she was having a lot of protein. It turned out that the patient ended up having FSGS, so he decided to treat the patient with more prednisone. This patient already had immunosuppression, right? So he gave her more prednisone. I don't blame him because he was trying to help the lady who was rapidly losing her kidney function. The lady got admitted with a very serious fungal infection called mucormycosis. I don't know if you heard about mucor. That disease is a very serious complication. The lady got the orbit was taken out. That wasn't enough. They scraped the whole, like it was like a horror movie. They were like removing all the bones from her face, and she made it, which is she's very lucky because most patients with mucormycosis end up dying. So the next question you need to ask yourself is, do you want to biopsy a patient? If the answer is yes, what am I doing with this information? That's the next question. So severely ill patients, multiple comorbidities, coagulopathies, non-compliant patients, I don't biopsy. And just for the sake of knowing what you have, I don't biopsy. If I tell the patient, like, will you be able to commit to immunosuppressive medications? And if they say yes, you do it. If you have a patient with very high risk of developing diabetes and you're going to hit them with prednisone, this patient is not going to do well. You have to think about these things ahead of time before you end up doing it. But I concur with you guys. This is a clear-cut indication for doing a renal biopsy. So, okay, so why don't we read the next paragraph? The patient is informed.
The patient is informed of his diagnosis of nephrotic syndrome and the potential benefits and risk of a kidney biopsy and looking for the etiology of this problem. He consented and the procedure is done without complications. The results of the biopsy showed evidence of membranous glomerulonephritis.
Okay. So how common is membranous? You guys think this is common or this is not common?
I thought I remember it was like one out of all the glomerulonephritis, this is the most common?
No, it actually, FSGS.
Oh, FSGS was the most
It used to be the third one, but now with the obesity,
okay.
we're seeing it more and more commonly.
Okay.
Membranous is probably the second one. IgA nephropathy is also in that category, but I would say probably the second most common one. So, yeah, and like I said, we have primary membranous versus secondary membranous. Primary membranous, we have a test available. It was FDA approved a couple of years ago. It's called the anti-PLA2 antibodies, antiphospholipase A2. I think that's the target of the antibody, and that test increases the sensitivity and the specificity, and is indicated for patients that are not candidate for renal biopsy for whatever reason. I don't think it replaces the diagnostic role of a kidney biopsy because, like I said, guys, the biopsy, to me as a nephrologist, it gives me important information. If I know that a patient already has advanced kidney disease, I know that I probably lost that battle, but I'm not going to lose the war because I'm preparing the patient for a transplant. If I hit the patient with heavy weapons and the patient gets very sick, if the patients get very sick, they end up developing, more complications and malignancies. Remember, these medications, they have risk of developing cancer, developing lymphomas down the road. And I used to have an attending that she would always tell me, like, rheumatologists, they love to prescribe these medicines, but these medicines, they have serious side effects that are not seen like down the road, like 20 or 30 years after these patients come up with all sorts of malignancy. So you want to be very careful about the use of these medicines. Okay, so can you determine the etiology of the glomerulonephritis based on the biopsy? Yeah, I mean that's basically the purpose of doing a biopsy, and to offer the patient the treatment, the risk and benefit of each treatment. Okay, so we talked about the secondary causes of membranous, like parasitic diseases, viral hepatitis, particularly hepatitis B. For membranous, it's B. For hepatitis C is associated with several forms of renal disease, but the most common ones are cryoglobulinemia. Have you guys heard about cryo? It's it's deposition of these antibodies, the IgG antibodies. They look like rheumatoid arthritis antibodies, the RA, the rheumatoid factor. Right. When they're cold, they precipitate, and that's why as soon as you get the sample, you need to put it in ice. They have, but hepatitis C can cause cryoglobulinemia, and it can cause another form of kidney disease called membranous proliferative glomerulonephritis. Not membranous, it's called membranous proliferative glomerulonephritis. Okay, and solid tumors. So membranous, you mentioned Hodgkin's and minimal change. Membranous is associated with solid tumors, gastric and breast primarily, but any solid tumor can present with membranous. So every time I have an adult with membranous, I always do age-appropriate screening for cancer, and if I have a suspicion, I just pan-CT them to find out if there's anything wrong with them. Okay, so what's the prognosis of membranous? So for practical purposes, I always remind students, remember like the rule of the 1/3. 1/3 of the patients, they go into a spontaneous remission with no treatment, and that's one of the reasons why we wait for 6 months. Let's say that I have a patient with new onset nephrotic syndrome, I biopsy the patient, and I establish that he's membranous, primary membranous. I leave them alone, and I follow them in clinic, and I determine whether or not I want to treat them with immunosuppressive. After 6 months, if the patients are still having severe proteinuria, I sit down with them and I tell them, like, I think I don't think you're gonna go into spontaneous remission. So 1/3 of the patients they go into remission with treatment, and 1/3 of the patients they go into end-stage kidney disease with or without treatment. So it's usually an easy way to remember what's the prognosis for membranous. And basically, see what I wrote here. Okay. Okay, and there are prognostic indicators. For instance, if the patient has heavy proteinuria, like more than 8 grams, I know for a fact that this patient he falls into the high-risk category, so I may expedite treatment versus somebody with 3 grams. So remember, in nephrology, more proteinuria carries a worse prognosis in general. Okay, so how do we treat membranous? We combine cyclosporine with prednisone. I think you guys don't need to know that. Most patients do respond. And why don't you read the last sentence there?
The patient is informed of his prognosis and the diagnosis of membranous GM. He has started on a course of corticosteroid therapy in conjunction with cyclophosphamide. He will be followed up closely for side effects of the medication as well as the effect on the patient's renal function as well as level or proteinuria.
Perfect. I want to finish this case with an important clinical aspect of nephrotic syndrome. And I want to ask you guys if you know what are the complications of nephrotic syndrome. Because you need to know this for your boards and for your clinical practice. What are the complications, like extra-renal complications of nephrotic syndrome? You guys know?
Edema.
Yeah.
Edema, yeah. What else?
Stroke.
Yes, accelerated atherosclerosis, because they get so much upregulation of albumin and the how do you call the enzyme that Lipitor blocks, the HMG-CoA reductase, that these patients have overexpression of cholesterol molecules, and it's one of the very important therapeutic goals to treat the lipids aggressively, because if you don't treat them, they develop accelerated atherosclerosis and they die from cardiovascular disease or cerebrovascular disease. Okay. What other complications do you guys remember from nephrotic syndrome? From pancreatitis?
Yeah.
If they have severe hyperlipidemia, hypertriglyceridemia, they can develop pancreatitis.
Electrolyte imbalances.
Yeah, but more specific to nephrotic syndrome. If you're peeing massive amounts of protein, what else do you think you're losing? You're losing proteins in the urine, but what else are you losing?
Immunoglobulins.
There you go.
So you're immunocompromised.
There you go. So these patients, they become very susceptible to develop infection by encapsulated organisms. Like that's why we want to give them the Prevnar, we want to give them Pneumovax, we want to make sure that if they're high risk for meningococcal disease, we vaccinate these patients. What else? What other complications?
Coagulation.
Coagulation, there you go.
You're losing your coagulation.
Your natural anticoagulants, the protein C and protein S, and you're hypercoagulable. So
you can also lose antithrombin.
Right.
Be hypercoagulable.
Right.
Technically, right?
Yeah. So these patients, it's not uncommon that they develop DVTs. So in Europe, the standard of care is to anticoagulate patients with massive nephrotic syndromes. In the United States, we don't do it routinely. I only do it when the patients have a DVT or an event. But that's basically another complication.
Anticoagulate with what?
Warfarin, with Coumadin.
Okay.
Yeah. So, and the other complication that these patients may develop is they become profoundly vitamin D deficient. They lose it in the urine as well. So those are the things that you need to know when you have a nephrotic syndrome patient. It's not just the renal aspect, but it's the total. And if you don't pay attention to those things, you can lose your patient. It's actually serious complications from not treating.
How about anemia?
Anemia, yeah. I mean, from if they develop renal disease, because EPO production.
The EPO goes down.
Goes down. Yeah. But it's important that you guys remember to treat the whole nephrotic syndrome. So you treat the blood pressure, and it is very important that you early in the course of the disease, you need to teach the patient the importance of sodium restriction. Otherwise, these patients become anasarchic like nothing, and fluid restricted diet. You need to teach them that, and that's fundamental part of the education of every patient with kidney disease, and in particular patients with severe nephrotic syndromes. You need to teach them that. Okay.
Cyclophosphamide.
Yes.
Is the side effect like a bladder thing?
Yes.
Okay.
Hemorrhagic cystitis.
Hemorrhagic. Okay.
And transitional cell carcinoma. When you don't.
I need to talk like a doctor soon.
Yeah.
Bladder thing. Okay. Hemorrhagic. I'll get that. Okay.
Very good. All right. So let's talk a little bit about hypertension. I got this little guideline that I brought from. I'm the hypertension champion for my medical center. I keep. By the way, pass my boards, Dr. Spencer. So anyway, so for blood pressure, so you guys know about hypertension, you know about definitions, you guys know about these committees. It used to be called the JNC 8. Unfortunately, this is the last time ever that they met, and they released guidelines, and the guidelines are a little more liberal. And I want you to understand this information in a different, for patients without heart disease, because as Dr. Benzer will explain, for him, for instance, it's very important for patients with severe cardiomyopathy or severe heart disease. His blood pressure targets are different than the blood pressure targets that we have for the general population. But generally speaking, we want our patients to have a blood pressure of less than 140 over 90. And you know, we always cover the basic things when we're confronted with hypertension, and we always talk about the importance of like an adequate reading. I cannot overstate this enough, because most people, they don't know how to check blood pressures. They either do it when the patients are crossing their legs, or when the bladder is full, or when they have a full meal, or when they have caffeine, or when they have inaccurate instruments, or they just don't know how to do it because they don't position the arm in a correct way, or the patients are talking while they're having the blood pressure check. There's so many technical aspects that I want you guys to review the technique and the size of the cuff. Remember, if you have an obese patient, you know, it needs to cover at least 80%. You know, how do you call that? You know, the cuff needs to exceed at least 80% of the size of the arm. So all of those things have an important impact in decision making and obviously in the overall prognosis. But when you rule everything out, and when you already establish the diagnosis of hypertension with 2 different readings greater than 140, then you design a therapeutic strategy for patients. So the board question is always, you want to attempt lifestyle modifications. Unless the patient has severe hypertension, you know that they're probably not going to get away with just lifestyle modifications. But the things that we advise our patients, Dr. Benzer is an expert, and you guys probably already experts about the low sodium diet, more like DASH type of Mediterranean diet, and including increased activity and weight reduction, because just with diet we're able to bring down the systolic blood pressure by up to 6. Some studies suggest at 8, and some studies suggest 10 millimeters. That's huge. That's actually the same as basically taking one medication. So we always want to encourage healthy lifestyle in our patients. We always want to educate our patients about the role of sodium intake in the development of these abnormalities, and we always want to encourage the patients to actively participate and measure their blood pressures at home. We have tools to be able to monitor blood pressure. We're not going to get into that, but you may get tested about this new modality. It's called the ambulatory blood pressure monitoring, which is important to know a few things about it. Number one, in terms of ambulatory blood pressure monitoring, it has a role in diagnosing patients that they may have. There's two scenarios. One is called white coat hypertension. Is the patient that always is high here, but the blood pressure may be normal at home. So you do an ambulatory blood pressure monitoring, and that tells you that gives you a daytime average, it gives you an evening time average, and it gives you a 24-hour average. And based on those numbers, you can determine whether or not it has white coat hypertension, or to diagnose patients with masked hypertension. Let's say that they come to the office, blood pressure seems to be normal, but Dr. Benzer does an EKG, and he noticed the patient has LVH, or he does an echo, and he notices that there is an intraventricular septum thickness, and those patients may have masked hypertension, which is something that it's easy to rule out with the ambulatory blood pressure monitoring. The other role of the ambulatory blood pressure monitoring is the fact that it has prognostic implications. Everybody has a normal dipping pattern when we sleep, and it's expected that when we sleep we drop our blood pressure by 5, by 10, sometimes up to 15 millimeters when we fall asleep. Patients that have a non-dipping pattern those patients, they have a much higher risk of developing complications of hypertension. We know them all: heart disease, cerebrovascular disease, all those things. But especially African Americans with a non-dipping pattern, those patients, clinical studies have consistently shown that those patients, they have an increased incidence of adverse outcomes. Okay, so having said that, you always teach the patients that there are medications that can raise blood pressure. We know them all, like NSAIDs is one of the most common ones. Inhibits prostaglandins, which are the natural vasodilators of the renal arteries, the renal arterioles. Stimulants is very common that people use decongestants, or they use Sudafed, or they use appetite suppressants, or they use like one of those like things that they sell them in every supermarket, like 6-hour energy, whatever the BS that they sell, and people spend money on those things. So those things, they can cause hypertension. For females, if they're taking OCPs, that's associated with hypertension. I guarantee you're going to get a board question with a young female with hypertension taking OCPs. The most appropriate step is to stop or switch the OCPs to something else and to reassess. You're going to get that question. So, and same thing for postmenopausal female with hormonal replacement or with estrogen-based therapies. The next step is to get them off the estrogens, and that will help also rule out medication-induced hypertension. Afrin, oxymetazoline, phenylephrine, some of the appetite suppressant, the hydroxycut. So there's a long list of things that can contribute. Alcohol intake is being studied, and it really has to be like probably like more than 5 servings to make a huge difference in your hypertension. But generally speaking, we don't want to advise the patients to have a lot of alcohol. It's common in our culture that people have like 1 serving of wine, but people usually underestimate the amount of alcohol that they have. But it's always important to ask when you're doing your interview about the amount, the choice of alcohol, and how many servings. And obviously, drugs like methamphetamines and cocaine, all those things are associated with hypertension, renal infarction, horrible complications, cardiac complications. Okay, so you do your homework, you go over everything, and once you establish the diagnosis, you're confronted with a patient with hypertension. So what do you guys know? What's the choice of therapy? How do you treat hypertension? When we already established everything else that we talked about, how do you start approaching a patient with hypertension? So
first, getting a baseline, getting a history,
right.
Their
So
caffeine
we already know that the
all
patient has
that.
hypertension. You're gonna move on with therapy.
ACE inhibitors.
Is that the first choice?
No,
Right.
ACTC.
Well, thiazides and amlodipine are the first choice of medications, but I take that back, Raymond. In patients with kidney disease and hypertension is the first choice. In patients with heart disease and documented LVH is the first choice. In patients with proteinuria is the first choice.
Okay, so ACE is the first choice for
Right.
heart.
For heart, I mean, if a patient has like LVH or cardiomyopathy, they should always be on an ACE inhibitor. We know that for a fact. The same thing with renal disease, if the patient can tolerate it, because hyperkalemia becomes an issue. But most patients with renal disease, they will be able to tolerate the ACE inhibitors for as long as you educate the patients about the side effects from the very beginning, and you ask for some sort of commitment, because many foods in our diet contain potassium. Do you guys know some of them? You guys, when you advise a patient, you're gonna start in one.
Bananas.
Yes.
Bananas. Okay. What else? Yeah.
Pistachios.
Nuts. Yeah. Any type of nut. Avocado has a lot of potassium. What else? The list is very long, and that's why you have to really commit the patients from the beginning if you want to succeed with ACE. And ACE is a very powerful tool. I have to have a very, very powerful reason to get somebody off an ACE inhibitor, because I know I'm helping the patients with these medications. What else contains high potassium? Orange juice, oranges, tomatoes, potatoes. Seaweed has a lot of potassium. Molasses is a big no-no. It's huge in potassium. Avocados. what are the fruits that kidney disease patients can have? So they are low in potassium. So like apples are low in potassium, grapes are low in potassium, but remember, it's not just the choice but the quantity. If you tell a patient, oh, you can go ahead and eat grapes, but the guy eats like a whole container, obviously your potassium is going to be high. But it's the choice and the quantity. So pears can be eaten by kidney disease patients. Canned fruits, they're not very healthy, but let's say pineapple or like peach, canned peach. The beans, you can eat them, but typically we tell the patients to like double boil, like soak and then get rid of the water and then do it again, because that way you eliminate a lot of potassium. Yeah, so in general, most patients with kidney disease, they will tolerate an ACE inhibitor regimen, and just make sure that you do emphasize to the patients that they need to commit to a low potassium diet if they have kidney disease. Every time you start an ACE inhibitor, you're expected to check a chemistry within a week or two. You guys know the reason why we do that? When you start an ACE inhibitor?
Renal artery stenosis.
Right, the patient has, in fact, ACE inhibitors are the treatment of choice for renal artery stenosis. Believe it or not, you're probably gonna say like, this guy's crazy. No, it is the treatment of choice, but you gotta use it cautiously. You gotta follow the kidney function. It is expected to have up to 20% decrease in the filtration after you start an ACE inhibitor. Some doctors freak out and they stop it. I don't think there's a reason to stop it. You just keep following. You tell the patient, come back next week, we're gonna repeat it.
On our board exams, is it ACE inhibitors okay with renal artery stenosis?
It is.
Okay.
It is, for sure. In fact, it is okay in bilateral renal artery stenosis. But I would never encourage any of you guys to do it, because that needs to be supervised by a kidney specialist or by a cardiologist, because you have to know what you're doing. I mean, if you just give an ACE inhibitor and you forget about it, you can get sued for that. It is the treatment of choice because it's a renin-dependent disease, and you're blocking renin by giving an ACE inhibitor. So you should always check it, and it's estimated that your GFR is going to drop by 20%. Typically it's a transient drop and the patients kind of stabilize, or maybe they have a little diminished kidney function, but the overall benefit is long-term benefit. And again, it's pretty powerful. We should always give patients with these conditions an ACE inhibitor as a first line. But for general population, healthy people, we have the option of doing a thiazide diuretic, either hydrochlorothiazide versus chlorothalidone. More clinical studies are favoring the use of chlorothalidone. It's a very old drug, it's probably from the 1970s, but it does give us a longer duration of therapy. Like when they compare head-to-head chlorothalidone and hydrochlorothiazide, hydrochlorothiazide has a half-life of 18 hours, whereas the other one confers like a 24-hour protection. So I always try to start patients on chlorothalidone. Sometimes the patients, they don't want to take two pills, and they prefer to use a combination. So we have, combinations of hydrochlorothiazide with lisinopril. That's called, I think, Zester. I think that's how it's called. I'm not a big fan of starting those medications at the same time, because the patients develop a side effect. You don't know which one, and you want to start with one agent at a time. Do you guys know what the side effects from the thiazides? Like a few that you're going to be tested on your boards?
Hypercalcemia.
Hypercalcemia, very good. Hypercalcemia. Hyperuricemia. What else? Hyperglycemia. What else? Hypokalemia. What else? Which one is the serious one? That's the reason why you have to check a chemistry 1 or 2 weeks after, especially in elderly females.
Osteoporosis.
You gain.
No, you can get
Calcium.
It's a severe electrolyte abnormality that you can see in elderly females.
So
Hyponatremia.
Oh.
Hyponatremia. Yeah. In fact, you don't want to start.
Like the first.
That's the first one.
Yeah.
So in fact, you don't want to start a hyponatremia patient on a thiazide, because chances are you're going to only make it worse.
But
So-
would any of the diuretics, would they lead to sodium loss?
No,
So,
no. In fact, if a patient has cardiogenic, like hypervolemic hyponatremia, we treat them with Lasix. That's how we fix the hypervolemic hyponatremia. You can have hypovolemic hyponatremia. You don't want to give Lasix to those patients. But for both SIDH and for hypervolemic hyponatremia, Lasix works very well. Yeah, but the thiazides is a big no-no if you have hyponatremia, and you should always check the chemistry. So thiazides are great drugs, but they do have side effects, and you need to know them for your boards. You're going to be tested on those. Gout, you mentioned it. Okay, so calcium channel blockers on the JNC8 committee, they also put them at the same level as the thiazide diuretics. So we have the dihydropyrimides and the non-dihydropyrimides. So side effects from the calcium channel blockers, you guys remember?
Gingival hyperplasia with diltiazem, maybe verapamil.
Even with Norvasc.
Okay.
Yeah. What else? It's a very common side effect.
Hypotension.
All of them. What else? Which one is a very common side effect from calcium channel blockers?
He just said.
Oh, peripheral edema?
Peripheral edema, yeah. Constipation is a side effect.
Constipation, sure.
Yeah, so remember the amlodipine has really no effect on on the chronotropic function of the heart. So amlodipine and nifedipine, although nifedipine can cause a lot of reflex tachycardia. I don't like to introduce nifedipine without having the patient on a beta blocker first, because they may feel very uncomfortable. They feel like they can have palpitations and they can have like a reflex tachycardia. It doesn't happen as frequently with amlodipine. But amlodipine, we use it also for cardiologists. They use it all the time for angina, and it's a great drug because you don't need to check labs, and that's a big plus for patients that don't have insurance or they have limited access to healthcare.
Is it okay for pregnant women?
Yes, but it's not the preferred drug for pregnant ladies. We usually give alpha methyl dopa. We give hydralazine, and we try to stay away from ACE inhibitors are contraindicated.
And nifedipines, no?
Nifedipine, they can use nifedipine, but before, years ago, they used to use it a lot in preeclampsia. Now there's a big black box warning against the use of nifedipine in preeclampsia because you wanna treat these patients with short-acting agents. You don't want to treat them with a medication that can induce severe hypertension, and that's nifedipine. Nifedipine is pretty powerful. It's long acting, and you don't. Whenever you're dealing with an acute hypertension, you want to treat these patients with either quinine, which is not a great drug for chronic management, but it works very well because it's short. It's a short half-life, and you also want to treat them, with either if you have captopril or if you have hydralazine, is also very short, and then that's another medication you can use. Okay, so calcium channel blockers, either the dihydropyrimides and the dihydropyrimides. We have okay. So what else do you do when you have a patient? You already have the patient on 2 agents, so you can look at the algorithm. So you have a patient with already with a thiazide diuretic, so you want to maximize one agent before you move to the next agent. So if the patient is tolerating the thiazide, you can go up to 50 milligrams, either hydrochlorothiazide or chlorthalidone. If the patient basically has, if the patient, you want to start him on an ACE inhibitor, you can choose a combination, but there is not such a thing as a combination chlorthalidone with an ACE inhibitor. So that's one of the limitations if you're planning on putting the patient on one agent. And why is this important? Because sometimes the patients, they don't want to have 2 copays, they want to have 1 copay. So I'm just bringing it up. But my preference is usually chlorthalidone over hydrochlorothiazide. So if they're not in control, the next step is to add a calcium channel blocker, like we talk about usually amlodipine. You start with either 2.5, 5, or 10 milligrams. Some doctors give more than 10 milligrams. It's not harmful to do that, but I don't think the beneficial effect of amlodipine beyond 10 is probably not very good. So, typically we wanna keep the patient with a maximum dose of 10 milligrams. There was a common practice a few years ago that was refuted by a very famous landmark trial. It's called the On-Target trial. I don't know if you guys reviewed that in med school, but the On-Target trial, it was run by cardiologists. Actually, they concluded that combining ARBs with ACE inhibitors is not beneficial. It actually has an increased risk of syncope, an increased risk of renal failure, and it's really not beneficial. So some nephrologists, they're still doing it for proteinuria reduction, I think that's not a good practice, and I don't endorse that practice. So there's no reason to combine an ACE inhibitor or an ARB. You give one or the other, but not both. Okay, so if they're not in control, so you can add a beta blocker. The JNC8 guideline recommend against the use of beta blockers as a solo therapy for hypertension. It's a weak, they're weak agents and they have side effects. You guys know the side effects of beta blockers? Fatigue, yeah.
Bronchospasm.
Yeah, for severe COPD, relative contraindicated.
Oh, if they discontinue, they gotta get reflex tachycardia. I don't know.
Yeah, you can, if you stop it abruptly, beta blockers and clonidine should never be stopped abruptly. You need to taper because you can have rebound, whatever, hypertension, tachycardia. Beta blockers, decrease libido, energy, very depressed, right? You're going to use them a lot for stage anxiety and for they work very well. They're very good medication. In fact, when you take patients off, they start feeling all sorts of symptoms, palpitations coming back. I love the beta blockers, but the point that I'm trying to make is that they're weak agents and should never be used as a solo agent for hypertension management. They can give you nightmares. Actually, a lot of patients complain of nightmares on beta blockers. Okay, and then you can either do that or you can add spironolactone. Spironolactone is a very powerful antihypertensive medicine, and it's also a favorite for cardiologists and nephrologists because we know how detrimental aldosterone is in the body. We have aldosterone receptors everywhere, in the endothelial cells, we have in the brain, we have it in the gut, we have it in the kidneys. So, and for some patients, especially those with secondary hypertension, because they have Conn syndrome, you guys remember what Conn syndrome is? Primary hyperaldo patients, then the classic board question is they have a guy with a patient relatively young age with hypertension, hypokalemia, and metabolic alkalosis. That patient you need to suspect primary hyperaldo. And the way you do it is by ordering renin and plasma renin activity and an aldosterone, serum aldosterone level. And
it's a ratio, right?
there is you look at both. You look at the aldosterone level and the ratio. If the aldosterone level is greater than 20 or the ratio is greater than 15, is suggestive of primary hyperaldo. Yeah, so but regardless whether or not your patient has primary hyperaldo, spironolactone is a very good medication. It has side effects. You need to get familiar with the side effects. You guys know the side effects from spironolactone? Gynecomastia.
Decrease libido. It's like it like decreases your testosterone, or it binds.
It blocks the mineralocorticoid receptor, and then the aldosterone receptor, and then it's great for ladies. Give you prevents hair loss. In fact, dermatologists use it for that. Dermatologists use it for hair loss.
Oh.
Yeah, it's for androgenic alopecia. It's one of the treatments. It causes hyperkalemia, especially in combination with ACE inhibitors or ARBs. So you got to be cautious and you got to emphasize to the patients that they really need to pay attention to the potassium, even if they have normal renal function. I do this combination a lot because in nephrology we also have a lot of anti-proteinuric effect, and it helps dropping proteinuria. For cardiac patients, it's great. I mean, if a patient has cardiomyopathy, it has all sorts of remodeling effects and aldosterone blockade. So, and we should always basically do it in patients with resistant hypertension. That would be the next step. And that's actually what the new guideline is favoring, the addition of aldosterone antagonists. We also have another aldosterone antagonist. It's called Inspra or eplerenone. It's typically in hypertension we don't use it much. For heart failure, I think cardiologists probably use it a lot more than we do. It works different in a way that it doesn't block the aldosterone receptor, but I think I can't remember exactly how it works. I gotta look it up, but it's not the aldosterone receptor. It's another pathway that it blocks. But it ultimately is one of the aldosterone blockers, and that's also an available option. But you shouldn't combine both; it's one or the other.
Does it block the principal cells in the distal tube? No.
No, I forget how it works. Let me look it up really quick.
Well, I remember one of the things that it doesn't have the gynecomastia.
Yeah, it doesn't have the sexual side effects.
And it's not intended for for primary hyperaldosteronism. It doesn't work because it doesn't work the aldosterone receptor. That's why I remember that. Let me look it up. Inspo. Pharmacology. So as it antagonizes the aldosterone-specific mineralocorticoid receptor, decreasing sodium and iron reabsorption and increasing potassium receptor. Aldosterone-specific mineralocorticoid receptor. I guess it's similar. Antagonizes the aldosterone-specific. So it's just the aldosterone-specific. I don't know. I honestly don't remember, guys, how it works. Okay, so if the patient still doesn't have controlled blood pressure, so you need to address things like non-adherence. With the electronic health record and the pharmacy records, you can easily tap on these patients that are not compliant, that are playing games. But it's very common. Actually, medication is non-adherence is very common. It's a very common clinical problem. Pharmacists have done all sorts of studies, and you should always consider that as part of the differential. So you need to think about interfering agents like NSAIDs, alcohol excess, the white coat effect, like I told you, and the way to do it is by doing home monitoring or doing an ambulatory blood pressure monitoring. So if the patient is still having hypertension, just one of the tricks I do is I stop the lisinopril hydrochlorothiazide, I put them on chlorthalidone and lisinopril, because you're maximizing the doses of the chlorthalidone and the lisinopril. So again, it's important that you maximize. Before you go to the next agent, try to maximize the ones that you already put the patient, if the patients are tolerating them. And you can start considering additional agents like hydralazine, terazosine. Let's say you have a male with BPH or like nocturia. This is a great medication. It does help. What are the side effects from terazosine? You guys know? It's an alpha blocker. Orthostatic hypotension, right? Orthostatic hypotension. So have that in mind, and always start with low doses and titrate as tolerated. You don't want to start terazosine of 10. That's not a good practice. I mean, patients, especially elderly patients, are not. They're gonna have issues with that. And minoxidil, I don't like it personally. I know a lot of doctors that use it. I think minoxidil it causes a lot of renal sodium retention, and it has significant side effects. One of the serious side effects, it can cause pericardial effusion, and it can cause actually pericardial tamponade. I had a patient who developed that. But it's one of those things that you move, like when you have no option and you don't really know how to treat these patients. So that's still on the table. But generally speaking, I don't like it. So other strategies, if not in control, you can stop the atenolol and add diltiazem to amlodipine, and making sure that the heart rate is greater than 55. Remember, when you add diltiazem, and the patient is already on a beta blocker, you can cause like bradycardia, like AV nodal dysfunction. So you gotta, we use that combination on occasions, but I wouldn't recommend you guys as primary doctors doing that. It's more like for cardiology level to do that combination. So I generally tell people to avoid using clonidine, verapamil, or diltiazem together with a beta blocker for the same reason, for the augmented AV nodal blockade. They can cause symptomatic bradycardia, and patients can end up with a pacemaker. But and then you move on to the secondary etiologies, and that's a whole different talk. I mean, if you guys are still here, I can give you guys a talk about secondary hypertension, and then obviously, if you do your ABCs, which is interviewing the patient, covering the basics, medication adherence, alcohol, stimulants, caffeine, all these things, NSAIDs, estrogens, compliance with medications, I guarantee you're gonna have probably 95% of control of your patients. And you go on a step, incremental approach. And you always need to emphasize lifestyle modifications to your patients. Always. Exercise, weight reduction, decrease sodium intake. I guarantee you're gonna control most of your patients. Like very few cases, I do get referrals for management of complex cases of hypertension, but we're talking about a very few cases. Like we're talking about like weird deficiency, enzymatic deficiencies, and genetic disorders. That this is not the bread and butter. The bread and butter is the basics, interviewing the patient, medication adherence, and go over this flow that I just gave you guys.
That was great. Thank you very much.
Oh,
Yeah,
sorry.
thank you guys. Yeah. Any questions, no? Anytime, whenever you guys wanna have it.
When you were talking about uremia,
Yeah.
and the guy had thrombocytopenia, technically, doesn't he have pus? Hemolytic uremia syndrome?
They call it hemolytic uremic because
But it's
it's
with E.
associated
coli
with
infection, right?
right, or it can happen
But
in
it's a
the.
syndrome, so
it's a
this
syndrome.
technically is the.
They
he
call
has
it
a-
uremic because it causes kidney failure. That's why they call it uremic.
Yeah.
Hemolytic uremic. Yeah.
Hemolytic uremic
Yeah.
syndrome, yeah. And he has thrombocytopenia.
Right. And
uremia,
the adult
kidney
spectrum is the TTP. So for your boards, you think about the patient with fever, the pentad. Fever, neurological manifestations, hemolytic anemia, renal failure, and thrombocytopenia. So those are the 5
For
things.
what? For what?
TTP.
TTP. Okay.
Yeah. And it's important that you recognize that because the treatment is
Prednisone.
no.
No?
You can
Oh
get it
no,
wrong.
it's a.
Prednisone, but it's not the main treatment. You have to give them prednisone.
Plasmapheresis.
It's plasmapheresis. TTP. So when you see a patient with renal failure, fever, hemolytic anemia, they look at peripheral smear and you see schistocytes and thrombocytopenia. That's TTP and they're proven otherwise. And it's serious. You have to recognize that very quickly. All right.
Thank you so
All
much.
right, friends.
Thank
Thank you so much.
It's
It's so nice to see you.
the crash. I don't have to study for days now.
Yeah, that was good.
Yeah, so how long are you guys going to be here for?
We just finished this is our second week. It's a 4-week rotation. So including this, we have 3